Hello, ladies and gentlemen, and a very warm welcome to St Mary the Virgin Church in Chipping Norton and to the 11th of 15 planned meetings of the big health and care consultation, the Oxfordshire Transformation Programme. My name's Gavin Gray. I'm a freelance journalist. I'll be chairing the meeting. I used to live in Oxfordshire for many years, working for Central Television and also for Meridian. I am not part of the panel, but it's my role today during this 2-hour meeting to get as many questions, as many different voices heard as possible, and as many of the opinions or concerns expressed to the panel and questions. And to that end, I apologise if I chivvy people along or appear to move along quite quickly, but I'm just very keen to get as many voices heard as possible. I'll remind you later on of the different ways in which you can get in touch with those making the decisions and the consultation. There are all those on the back of the booklet that I know the middle 2 rows have. I think they're trying to hand out a few more that have come as well. So those are the different ways in which to get in touch. I'm also aware that some people don't particularly like to stand up and ask a question in public. And for those people, I'm very, very happy to take in a written question. So if after the presentation you've got a question, I think there are some small postcard notelets around. If you want to write a question on there, with or without your name, then I can ask that of the panel, time permitting. So that's another way in which you can get that particular question asked. A couple of housekeeping points. There is a fire alarm in various parts of the building. We're not anticipating it to go off, but if you hear it, we should evacuate. And the main door is that way, or indeed there's another door out through that particular direction. The toilets are both at the back. This is naturally a no-smoking building, and can I remind everyone, if they've got a mobile phone, if they can turn it off or to mute so that we don't get disturbed. This is a public meeting to which the media have been invited as well, and a recording is being taken. So everything that is being said is effectively on record, and there is an audio loop for those that need it, which is in the middle 2 sections here at the front. I'll ask in a moment the panel members to introduce themselves. Then there'll be a short presentation and a video. I know some of you may have seen it before, but I urge those just to watch it through again and let the others who haven't seen it have the ability to hear what is in that presentation, and of course it accompanies that booklet that you've got. At that point, I think it may help you formulate some of the questions which will then take up the majority of the meeting. And that'll be question and answer with the panel. At the end, I will then ask for a couple of the panel members to sum up, and we have this lovely church through until 8 o'clock, so a couple of hours' time. All right, no more from me at the moment. If I could ask each panel member to introduce themselves, and if I could ask Catherine Mountford, would you like to start?
So I'm Catherine Mountford. I'm one of the directors at Oxfordshire Clinical Commissioning Group, and I've lived and worked for the NHS in Oxfordshire for nearly 20 years now.
Dr. Paul Park.
Hello, I'm Paul Park. I'm a GP in Banbury at Hightown Surgery. I've been a GP in Banbury for 8 years and worked for the NHS for 14 years. And I represent the 100 or so GPs and their patients in North Oxfordshire, which basically goes from Chipping Norton to Banbury in the Clinical Commissioning Group.
Dr. Kira Collison.
Hello, I'm Dr. Kieran Collison. I'm a GP. I work in Witney. I've been working in the NHS for 14 years myself as well. I'm a mum as well, which is probably even harder than being a GP, to be honest. And that's led to my interest in the maternity work that I do. So I lead on maternity for the CCG.
Dr. Tony Berrett.
Good evening. I'm the Medical Director of Oxford University Hospitals NHS Foundation Trust. I'm the board lead for quality, which includes patient safety issues. I've lived and worked in Oxfordshire for the NHS for 30 years now, so I'm one of the veterans on the panel.
And Andrew Stevens.
Vying for the role of veteran. My name's Andrew Stevens. I'm the Director of Strategy and Planning for the Oxford University Hospitals. I've worked at the NHS for 34 years. The last 17 have been as Director of Strategy and Planning at the Oxford University Hospitals. And in that role, my job is to work with Tony, our other clinicians, nurses, and indeed our other partners, GPs, to help plan services for the local population that we serve.
So we have here tonight some very senior people in the county's NHS. I'll start off by asking Catherine Mountford, the Director of Governance at the CCG, if you would like to start the presentation, please.
So thank you everyone for coming tonight, and I'm going to give a brief introduction as to what we're consulting on and why we're consulting on it, and then I'll be handing over to Dr. Park, who will talk you through the individual clinical areas. So this is the first phase of our consultation. It started on the 16th of January and we are running till the 9th of April. And there are some specific things that we're consulting on, which is the use of hospital beds in our main acute hospital sites, so the Horton in Banbury and the John Radcliffe in Oxford. Issues around planned care at the Horton, and when we say planned care, we mean things like outpatient appointments and diagnostic tests. The acute stroke services across the whole of Oxfordshire, critical care at the Horton, and then maternity services at the Horton. And we've got a second phase planned for later in the year, and I'll talk a bit about why we've split it. But first of all, why are we consulting? What are the things that are changing that make us need to do this? So first of all, the population, the numbers living in the county is increasing, and we're all living longer. And that's really good, but it does give us more activity and more things to be done by the NHS. And also, the NHS is always working out new things it can be doing. So the funding that we're getting from the national government is not keeping pace with that growing demand. But here it is important to say NHS funding is increasing year on year. It's just not going up as quickly as the demand on our services and the need to deliver things is happening. We also all know that better prevention, so working more closely with our population and our local authority colleagues, will be better for all of us as individuals. It will improve our health and reduce the demand on the health service. Another thing that's important to us as a CCG, that although we live in a very well-off county with very good health outcomes and very good health on average, we know that's not true across the whole county, and we have pockets of deprivation, pockets where people have worse health outcomes than the rest of the county, and we want to address that. We're always learning and looking to see how quality and safety can be improved, and a couple of the areas we're looking at are absolutely about how do we ensure that the whole population of Oxfordshire gets access to the best quality care. The buildings and equipment we have across the whole county, some are excellent, some are new. So you've got some new facilities in Chipping Norton, both the general practice and the hospital. But we do have buildings on our main hospital sites and some of our general practices that are not right for delivering care in the current times. So we want to think about what premises do we need, what sort of equipment, and where do we need it. And also, to deliver all this care, we need workforce. And the current workforce model that we've got, the current ways we're delivering services, can't meet the demand that's coming. So why are we doing this in two parts? This is something we know is concerning the public, something that's come up in all of the meetings we've done to date. And there are multiple reasons for this. First of all, there's a large number of services to consult on and a lot of detail that's needed to do all of that. And for some areas, we are still working through that, still taking ideas in from these meetings and thinking about how those should be taken forward. But we have got some services that need urgent changes, and that's either because we know when they're not delivering the kind of quality and outcomes we should be delivering, or areas where we've had temporary changes in place. So the changes to our acute hospital beds and those services, we have had temporary changes in place, some beds temporarily closed since 2015, the autumn of 2015. And therefore, because we want to make this a permanent change, we need to be consulting on that. Again, maternity services at the Horton, the obstetric service has been temporarily closed since last October 2016. And we have significant workforce challenges there. So again, we want to quickly move on to what would be the right permanent solution so that patients and the public know what's going to happen, but so that we can have a stable staffing. For critical care and stroke services, as Dr. Park will tell you, that's absolutely about improving the quality and outcomes for the whole population of Oxfordshire, given what we know now. And then on top of that, there is the issue about investing in planned care services at the Horton. How can we have more services that are the right sort of services closer to the community so that people don't need to travel into Oxford if it's not necessary. And so all of this together wraps into what we're trying to deliver for the future for the people of Oxfordshire. We want that local access to diagnostics and expert advice where that's the right and appropriate thing to do to minimise the distance people have to travel. Where people don't need to be admitted to hospital, we want to prevent that admission. If you can come and be assessed, have your care plan put in place and got home with support, that's much better for you. As that statistic at the bottom of the slide indicates, that 10 days in a hospital bed is equivalent to 10 years loss of muscle strength for the over 80. So the longer we keep that people end up staying in hospital, the less likely they are to be able to get back to their former functioning. Again, the NHS is moving and has been developing its use of technology, but there's more that we can do. How can technology support care closer to home and high quality services? And then that all links to, whenever possible, the best bed to be in is your own bed. And now Dr. Park's going to talk in a bit more detail about the individual services.
Thank you, Catherine. Right, okay. Just before we start, yes, just to clarify, by the way, the numbers around how finances are changing. I think it's fair to say that there's been roughly a 1 to 2% increase in funding for the NHS compared to a 4 to 5% increase in need over the last 7 years. And these are straightened times for the health and social care system. I think we all know that. I think the BBC has made that pretty clear if no one else has. By the way, can everyone hear me? Good, fine, thank you. Okay, this bit is about using hospital beds differently, which is a little generic, isn't it? What this is about the fact that basically patients who end up being admitted to hospital often stay there longer than they have to, even when they are essentially medically fit to be to no longer be in hospital, because there isn't anywhere for them to go, because there isn't a care package for them at home, or there isn't a care home or intermediate care bed or whatever there is for them to go to. And these are what people in the know, as it were, refer to as delayed transfers of care, though, of course, the press has a more derogatory term for such patients, which is pretty rude. And for years, Oxfordshire has been the worst for delayed transfers of care in the country. It's been a county shame. But for the last year and a half, especially with the appearance of the new chief exec at Oxford University Hospitals, Bruno Holthoff, we've been doing that differently. We've been actually trying to move people more quickly through hospital, to get them to improve the number of care homes and care home beds and care packages that they can go into. All those things, just make sure people move more quickly through the system, and that's essential for making sure that they get the care they need when they need it. Obviously, I've worked as a junior doctor, and every person who's worked as a junior doctor or worked in the hospital at all has a horror story or 6 about patients who got more ill because they stayed in hospital longer than needed to. I certainly won't bore you with mine, but I'll start you on the video.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, we just thought it'd be good companionship for you, nice and sleepy together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The liaison hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The liaison hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
Okay, I hope that was informative. So our preferred option is basically change the way we work things in the way that I described and the video describes. By the way, this is one of the changes, and it's quite a big change, clearly, that the Health and Overview Scrutiny Committee, which is a committee of the County Council and the District Councils that decides on these things, said that we had to consult on as soon as possible. It is one of the main reasons we're consulting on this bit early, for want of a better word, in phase 1. So it's one of the major reasons we're here, as it were. And this has involved closing a certain number of hospital beds, but that's actually kind of required for making the system more flow better, work more effectively, and the feedback from it has been very positive. But let's move on. Okay, planned care. Planned care is everything that isn't urgent care. That may be a bit of a tautology, to be honest, but what that basically means is, and this is actually the good news bit, as it were, of things, is that there are going to be changes to the Horton, development of Horton, which means that up to 60,000 clinic appointments and face-to-face consultations, and up to 30,000 other things, which include day cases, scans, investigations of chemotherapy, will be done at Horton rather than or John Radcliffe, rather the Oxford Hospital sites in future. That's 90,000 things, if you like, a year, 300 a day, that will basically be done more at the Horton, and which will certainly be more convenient for my patients, and I'm very happy about that, to be honest. It would reduce the sort of transport issues and travel times and parking issues around Oxford hospitals, and I think it will be better for many of you too, to be honest, because generally speaking, it will be more convenient for you to go to the Horton. But I'll let the video speak to it.
Planned care is care that occurs outside of an emergency situation, and the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations, and if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis treatments in Banbury, but the plan is to enhance those facilities and increase access to more patients to be treated locally. Patients often have to attend hospital for several different appointments to have their investigations and their outpatient appointments and get their results at the end. So what we plan to do with a one-stop shop is to try and reduce the number of attendances patients would have to make. So although we're trying to deliver care locally to Banbury, we also want to reduce the number of appointments patients have to make to achieve their diagnosis and treatment.
Yeah, so I hope that seems fairly clear. Here's the audience participation bit. Who here has had to go to Oxford to John Radcliffe, to the Nuffield Orthopaedic Centre, to Churchill, either for their own thing or to take a relative, and had to drive all that way, or had to travel all that way. Who found that a fun experience? Yeah, I didn't think so either. I certainly didn't. And being able to get 300 a day, that's quite a lot of people who are no longer going. Think of the traffic. Who'll be able to get to Horton. I think that would be amazing, personally. And it's already started. Andrew Stevens informed me reminded me that they've recently taken delivery of the 64 slice, is it? Yep, 64 slice CT scanner, new one at the Horton. It did break down for 5 minutes, which is pretty embarrassing, but it's working again. So that's, I think, generally speaking, good news. Moving on. Stroke care. Okay, this is slightly complicated, but it's actually quite vital. The main thing about care of strokes and things like strokes, such as mini strokes, transient ischemic attacks, and non-disabling strokes and all the rest of it, is that basically treatment of them has significantly improved, certainly even since I was a junior doctor. And that basically means that the standard for what you can do now is much higher. There's so many treatments that are more advanced, more complicated, more exciting. But it basically means that you need a much more skilled centre to deliver them. And a recent national audit of basically hospitals that treat stroke around the country, it's called SNAP, I forget what it stands for exactly, showed that the Horton had basically some of the worst outcomes for stroke care in the country, because it was a place where patients was taken to when the paramedic who found them with a stroke decided that they'd had a stroke more than 4 hours ago, and therefore they were safe to go to Horton, when actually they couldn't really tell. So now the move is, and this is very much a safety and quality issue, is for all patients, including in North Oxfordshire, to be taken to a hyper-acute stroke unit, or HASU, as soon as they are seen, and that will improve stroke care, certainly in North Oxfordshire, certainly around Banbury, enormously. But again, video.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
And as we heard there, a major part of this isn't simply about the fact that people get taken to hyper-stroke unit and get better care. It's about the fact that they get better rehabilitation afterwards and are basically returned to their area as early as possible with as much support as possible. Critical care. Even more kind of complicated, but let's go into it. Critical care is about is the critical care unit in a hospital is where patients who suddenly take a significant turn for the worse, who need significant care, and have to go. And there are various levels of critical care. Currently, the critical care unit at the Horton, which is what this is about, is a level 3, which is the highest level. The problem is it doesn't see very many level 3 patients, the ones who are really ill, who need to be intubated and ventilated. And the thing is that if your team, your critical care unit team, doesn't see that many patients a year, then actually they get de-skilled. They don't have the experience to maintain the training and so on. And that means that their unit becomes less safe. And therefore, after careful examination of this issue, it was decided it would be probably best if the critical care unit at the Horton became a level 2 unit, and patients who needed level 3 would be in future seen at John Radcliffe, where the team does see quite a lot of people of that complexity all the time, would be able to give them the best possible care.
We have 3 adult critical care units at Oxford University Hospitals, one at the Horton, one at the Churchill Hospital, and one at the John Radcliffe Hospital. I suppose the levels of care reflect the complexity of care delivered to the patient and how sick they are. Level 3, which we sometimes call critical care, are for much, much sicker patients. These patients need advanced respiratory support, which is really the breathing machine, the ventilator. Critical care medicine is like everything else in life. The more you do, the more it becomes routine, and the surprises, the less they become unusual. If, as in the Horton, in the last year we had 40 level 3 patients, that means that's less than 1 patient each week, and in reality probably less than 1 patient a day. And that takes it into the numbers that makes managing them not routine, not normal business. Critical care facility at Oxford, there are about 1,900 patients there each year. So you can see immediately how the care of a critical care patient, which is never routine, but the general aspects of the care of a critical care patient becomes much, much more routine simply by having those numbers of patients.
And again, that is very much about safety and quality, best care for the patients who need it most. Moving on to the last and the most contentious, certainly in my neck of the woods. It is close to my heart in the sense that it makes me and pretty much every GP in North Oxfordshire heart sick, but it is unavoidable. I'm sure you've all heard about maternity at the Horton. Just to give the story in brief, so it will hurt less. In 2011-12, basically the Royal College of Obstetrics and Gynecology, who are the college that oversees training and governance for obstetric doctors, said that you have to be on a unit of a certain size to see a certain number of deliveries a year in order to have training, and that cut-off was 2,500 births a year, and the Horton had 1,400. And therefore, shortly after that, Health Education England withdrew training from the Horton Hospital, which basically means that you can't have training doctors, junior doctors, essentially, at the Horton, at the obstetric unit. This is very hard to manage. It essentially means you either have to use non-training doctors, which are quite a few, because you can only basically do it with doctors who have either given up on being consultants, essentially, or who don't need training right now, and put them in a middle grade rota, which is basically what the Oxford University Hospitals did for several years, maintained quite a delicate rota of doctors with academic interest in things, so you could get that support. And ultimately, it was a system that was fragile, and they kept on having difficulty recruiting to that rota, and eventually, in June last year, they couldn't recruit enough, and they had to declare that we had to change the way things worked. And that was awful for me, and for pretty much every GP I know in my practice and elsewhere in North Oxfordshire. That was awful because the maternity unit at the Horton was where many of us had trained. I didn't, by the way. I trained at Stoke Mandeville in Aylesbury for what it's worth, but many of my colleagues had. And it's to see that go, but to know that it was the only safe thing to do, to change it to a midwife-led unit which has been running since October, we are, I think it's fair to say, in saddened acceptance of the whole thing. And since then, actually, it's not been too bad. Quite a few of my patients go to Warwick's, quite a few go to John Radcliffe, and quite a few have been to midwife-led unit at the Horton, and that has actually been excellent and safe. And so basically what this bit of the consultation is about allowing that to continue as a permanent state.
We want to provide a high-quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of two groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
And once again, that is basically entirely about safety and quality. There is nothing less safe than an obstetrics unit that doesn't have any doctors. A midwife-led unit is safe and gives good care with excellent feedback for the women at the lowest risk of in their births. And difficulties in recruitment, loss of training, those things were unavoidable. Lord knows, as a GP in Banbury, I know that recruiting doctors is pretty difficult in these straitened times. And by the way, maternity, the changes to maternity at the Horton, was the other thing that the Health and Overview Scrutiny Committee, that committee I mentioned a few videos ago, also asked us to consult on as soon as possible. So it is the other main reason we are here, as it were, that there is a phase 1 to the consultation. Okay?
So we're coming to the end of the presentation. So just quickly to update you. So I think you've probably all been given hard copies of the consultation document and the survey. That can also be found on our website along with more detailed information. We've also been putting up some of the frequently asked questions at these meetings and answers. There's a maternity fact sheet that went up last week, and also the audio recordings of all our public meetings. The question and answer sessions can be found there. So there's lots more information you can access if you want it. There are multiple ways you can get in touch with us. So you can fill in the survey hard copy, you can fill it in online. All the questions that you're asking here are informing us. And also you can just write to the free post address. As Gavin said, this is the 10th of 15 meetings. We've been all round the county at a variety of times. Also, we've been into South Northamptonshire to Brackley once, and we'll be going there again towards the end of our public meetings.
Oh, I don't need that. Thank you very much, Catherine. OK, so I'm very keen to get lots of, I almost use the word ordinary, but members of the public and residents to ask questions. I do know we've got some councillors here who are very, very keen to ask questions as well, and I'm keen to hear their voices, but more I'm keen to hear your voices. That said, we are joined tonight, I'm delighted to say, by Robert Courts, MP for, Whitney and West Oxfordshire, a familiar-sounding constituency, and he very kindly organised, I think, tonight's venue, or suggested this as a venue. Would you just like to kick off? Obviously, we've got the background of yesterday's budget and the announcement of a bit more money, but there's a microphone there. Could we just get that round to the MP here, please? And if I could ask everyone, you won't need to do it, but if I could ask everyone else to just introduce themselves before they start.
Thank you very much. Firstly, could I thank the panel, please, just for coming out again, for sacrificing an evening, and for coming to Chipping Norton again, because, of course, we know you've been once already, but everybody here wanted to have their chance to have their say. So thank you very much to start off with from that perspective. I'd like to talk about, or ask you, rather, about maternity services, please, and just focus on that. That's of particular importance to people in Chipping Norton. Now, with the proposal that there is an MLU only at the Horton, we have particular circumstances here in Chipping Norton. It's a very rural area. It's very high, so we get snow here in the winter that you don't get elsewhere. And you are looking at a journey time to the JR of a good hour. And sometimes that's a best case. So it's a long way. And I'd just ask you to consider that Chipping Norton is a special case because of its rurality, because of the remote nature of it. Now, I'd like to ask you if you can reassure people here that Chipping Norton, its future, is 100% safe, because what people here fear is they'll only have an MLU at the Horton, and then will be faced in phase 2 with the loss of Chipping Norton as well, which would be disastrous for this area. Could you reassure us of that, please?
OK, thank you very much. MLU, midwife-led unit, just to explain so we don't get bogged down in acronyms. OK, so two-part question. First off, about the maternity services. Would you like to kick off with that? Dr. Kieran Collison.
Yeah, thank you so much for that question. And I know that is a question that a lot of people will be thinking. So, I mean, the way we're doing it, I mean, as you know, we're doing phase 1, phase 2. The way really HOSC, the Health and Overview Scrutiny Committee, have asked us to do it that way so that we can deal with the critical one, which was the maternity unit, becoming an MLU in the Horton. We were asked to look at that straight away, which is why we're focusing on that. But that doesn't mean to say we've totally forgotten about the MLUs by any means. That is officially coming in phase 2, so it's not something we're focusing completely on at the moment, but it's obviously on our radar. So it's something we'll certainly be coming to. And when we look at it, we'll be looking at the whole county and exactly, as you've said, been trying to look at where the best places are to situate those MLUs. As I said, we haven't looked in that in detail yet, so I'd be lying to you if I said, one way or the other what's going to happen, because actually I don't know yet. We need to look at the whole picture altogether. I think it'd be wrong to say something otherwise. But I totally understand where you're coming from. Even though it's not in this phase, I do want to hear what your thoughts are on it, because it will help to shape what we then look at when it comes to phase 2. And then when it comes to phase 2, we'll be consulting on that. So this is a conversation we can enter into again at that point.
Dr. Paul Park, did you want to add anything to that? OK. And just to be absolutely clear, the decision to do things immediately and then on to phase 2, I'll come to Tony in a minute, was made by HOSC. HOSC was members of councils.
Yes.
Okay. And the other thing, phase 2, what are the dates? What's the schedule? Catherine?
So for phase 2, everything we hear in these meetings is informing the thinking. We're in the options development phase. We will be having further engagement conversations over the summer. We wouldn't be out to formal consultation before the end of the year.
And Dr. Tony Berrend, you wanted to come in.
So I just wanted to come in terms of the travel times and the data that we've obtained linked to these proposals. Currently for North Oxfordshire population, 95% of women live within 30 minutes of an obstetric unit via blue light. That's if the Horton were open as an obstetric unit. That goes to 88% within 30 minutes if the Horton is no longer an obstetric unit, and still 100% within 45 minutes of Oxford. When you look at the national data of the birthplace study and other related studies, transfer times in general from the standalone MLUs into the centre are of the order of 30 to 60 minutes. And the evidence from the international studies and elsewhere around whether that's associated with measurable harm is that you can only get convincing evidence that there is harm at a population level when you've got travel times of over 2 hours. These tend to come from countries with very big geography like Canada and so on. So although everybody completely understands the anxiety that fuels the questions about travel time around what about an obstetric disaster and what impact does that have, we have to weigh that up against, one, the fact that an obstetric unit without doctors is not an obstetric unit and not a safe place for a woman experiencing some major complication of labour, and secondly, that at the population level, the fact that we can carefully assess risk, that we have escalating protocols to move women to the obstetric units from the midwifery-led units at early points in their labour if things are not progressing appropriately, is what ends up with having similar outcomes for the baby and better outcomes for the women in terms of less intervention, as has been described in the video.
Okay. There's a gentleman at the front pew just over the aisle. Yes, please, sir.
Thank you. My name is Andy Graham, and I'm a District Councillor in West Oxfordshire District Council. And I know West Oxfordshire District Council will be submitting their response in the next few weeks. What I'm concerned about, and what's not clear to possibly a lot of people here, is that this consultation is going on now. The results of that consultation, how does that get disseminated? And does that happen before we go into phase 2? In other words, the question is, does the consultation on phase 1, is it separated from phase 2? And also, how does the district councils and the parish councils, their consultation, feed into that as well?
All right. So, question there about how the two phases work together, essentially. Catherine Mountford.
So, as I said, this phase 1 consultation period ends on the 9th of April, and after that we will be taking everything we've received, so all the written responses, all the material from these meetings, and we've been doing some additional work going out to other groups. That's all being reviewed for us by an external company who will write us a full and detailed consultation report. So what have we heard? And that will be everybody's replies, and it will include things like the day at the Health Overview and Scrutiny Committee yesterday and all the submissions that were made to that. That will come to the Clinical Commissioning Group board meeting at the end of May, alongside an integrated impact assessment which looks in a lot more detail about the potential impact of these changes on particular groups of the population, picks up some of the travel issues, would suggest whether there were some mitigations we should think of. So all of that comes to us in May. The board will look at those, review those, think, does that mean we need to ask for further work to be done on the proposals that we're making? And we will ask the groups to do that. And then we are anticipating being able to make a decision on these areas in June, or not before June. So we are anticipating being able to make decisions on phase 1. And then we don't think that the decisions that we will need to make or the outcome will have any impact on the things that we need to look at in phase 2. That will be a separate set of proposals and decisions. Of the outcome. So the outcome of the consultations. Everything will continue to be published on our website, and we will make it very clear that our board meets in public. So the meeting in May and later will then be in public, and we will advertise those widely.
All right. Just a reminder, anybody that doesn't particularly want to speak in public, I'm very happy to take any written questions. There are some postcards floating around, I'm sure some pens. So if anybody, the lady at the back there is saying that, would you like to ask a question, or would you like the pen and paper? Okay, so there's a lady there just in a grey shawl. No, well, it's that way everyone can hear. Thank you.
Can I just clarify something? At the MLU...
Sorry, can you hold it? Yeah.
At the MLU, there is no doctor on site, there is no intensive bed, and it only takes 30 minutes to get to Oxford with a blue light. Am I right?
So what I said was from the MLU. No, it doesn't only take 30 minutes to get to Oxford. It's a little bit longer than that.
Right. So my granddaughter, who fortunately is alive and well and kicking, and was put into a cooling bed in intensive care from a hospital. She was in London. She would now be a vegetable. I mean, I think it is amazing that there is no doctor on an MLU when you're so far away from Oxford.
Okay, so obviously I'm sorry to hear about your...
No, she's
your,
fine. She's
experience.
fine, but
okay,
she wouldn't have been. Yeah. You know, and there must be many more like this.
Midwifery-led units never have doctors present. That's why they're midwifery-led units. That's why they operate according to very strict protocols around transferring across to obstetric units if the labour's not progressing well. And they don't have special care baby units attached to them because it is not correct for there to be that provision for the baby if you don't have the full obstetric provision present as well. It lulls people into a false sense of security. So the safety of midwifery-led units is all about careful assessment prior to labour, careful monitoring during labour, and rapid escalation if necessary. From Banbury, even with the obstetric unit, babies that are worrying when they're born have always been transferred to Oxford anyway. So the special care baby unit that there was in Banbury when the obstetric unit was open was always essentially just a post-labour ward. It was never looking after very sick children. So I think it's important to understand that distinction. Midwifery-led units are safe for the right group of women, provided you have these other escalation and transfer protocols. And it's exactly the same situation as pertains to the midwifery-led unit here in Chipping Norton, essentially. The unit here is safe because there is a whole set of escalation protocols that the midwives employ in order to get women to places of safety if things are not going well, and to move babies very rapidly if they're born and unexpectedly are not in good condition.
Dr. Kieran Collins.
Yeah, I just want to say I can really feel for you, and it is obviously a very emotive subject. And just to echo what's just been said, the key with all of this, a lot of this consultation is focusing around the hospital, the actual birth setting, but a lot of the work we're doing is actually taking it right back to when the woman first becomes pregnant and then presents to their GP right in the early days, and deciding who's potentially a high-risk pregnancy and needs to be in an obstetric unit with doctors, and which ones are classed as sort of low risk and could potentially give birth in a midwife-led unit. And deciding those two things right from the beginning and reassessing throughout the pregnancy so that you can make those decisions and make well-informed decisions about the safest place for you is a very important part of this. And, I mean, obviously I don't know your circumstances. I don't know, what happened there. But that really is the key, being able to assess what your risk is and knowing which is the best place for you to go to eventually.
I know there are two people. I've got my eye. Don't worry, I won't forget you. But there's a lady in a floral dress just in front of the pillar. Yes, you, madam.
Yes, good evening. It's Debbie Fry. I just want to ask a question. What plan do you have if somebody has a postpartum hemorrhage? I'll just give you the story. I was a fit and healthy woman and went into hospital, had a normal delivery, and I self-diagnosed that I was having a postpartum hemorrhage, and I was wheeled straight into the operating theatre within about 2 minutes, and my life was saved. But what would have happened if I was in the Horton Hospital, as it is now? I would have been considered a low risk because I'd already had a baby before that. So what would have happened to me, and what plan do you have if that happens now, either here in Chipping Norton or in the Horton, bearing in mind it takes 40 minutes from here to get to the JR on a good day?
All right. When someone appears to be low risk, but then might not be later on. Dr. Kieran Collison.
Yeah, that's absolutely the crux of it. You're absolutely right. And I'm sorry to hear that sounds awful. But that is the question that I get asked the absolute most. It's, what about the unexpected events like what you just explained? Unfortunately, with childbirth, it is a risky business. There's no way around that. That's just the way we're made. So there will be, like yourself, there will be women who are assessed as low risk, who might go to the MLU and who might then have a complication. There's nothing that you can really do to avoid that. What you don't want to do is go to an MLU, have a complication, and then hope that a doctor will be there, but there's not enough doctors there because on that particular day there wasn't enough to staff it, and therefore you're in real trouble because then no one knows what they're doing. There's confusion, there aren't policies in place to transfer you because one day there are doctors there and the next day there's not, So from that point of view, that would not be, you'd need to be transferred out of there quickly, have good policies in place to know that the transfer is going to be quick and seamless. And it's the same for any MLU around the county. It's not just the Horton, it's not just here at Chipping Norton, it's in Wallingford and it's in Wantages as well. There are policies in place for exactly that position so that the midwives know how to assess people in labour and after labour, to know when they become high risk and to know exactly what to do to transfer them in a timely fashion so that the outcomes are good.
Okay, and there was a lady in pink here. Yes, just second row back. I know there's a gentleman in the distance there. Yes, I'll come to you afterwards, sir.
Good evening. Marie Crossland. Sticking with maternity. The thing that concerns me, actually, I'm a big fan of MLUs. I had my son here. I would have had my daughter here, except it was closed, so I had to go to the Horton, and it now seems to have changed. And I didn't want to go to hospital. I wanted to have my daughter here and was delighted to be able to have my son here. So I'm horrified at the idea that our maternity unit may close. Please don't tell me that's going to happen. You've all got to promise that it won't. But I'm only one person, and I felt safer and more comfortable in a maternity-led unit environment, possibly even would have considered home birth. That's me. Not every woman feels like that. And the important thing here is that every woman should have a choice about where they want to give birth. And I know many people here locally who didn't have the same views as me. Many of my friends, who had babies at the same time, for whom going to Banbury was the thing for them because they wanted to be in a hospital environment. They wanted to be somewhere where they had doctors right there. And anyone who's been in labour does not want to have to travel to Oxford. It doesn't matter. This is not if it's an emergency. A routine labour starting quite spontaneously, you do not want to have to go to Oxford in an hour, round all those roundabouts when you're in labour. That is just a horrific idea. It took me 5 minutes to get from my house to the MLU here in the car, and that was enough. Okay. So how can you guarantee that women are going to have choice about where they give birth?
The choice, women's choice. Dr. Tony Barrett.
So I think what we're saying is the choices will be that women could choose to opt for a home birth if they're deemed to be safe enough and can get support for that. They can opt for a midwifery-led unit that can be one of the standalones, which would be Horton and others that you've already heard mentioned, including Chipping Norton. Or they can opt to have an an alongside midwifery-led unit birth, which would be the Spires unit at the John Radcliffe, or they can opt to have an obstetric unit delivery, which would be in Oxford, or for people up in the north of the county, there's the option for Northampton or South Warwickshire. Organisations that we have talked to, that we know have capacity, that understand our plans and are perfectly happy to support that. And indeed, since the temporary suspension of the obstetric unit and transfer to midwifery-led unit, a number of women from the north of the county have booked across to South Warwickshire and Northamptonshire. So that's already happened to some extent. There were about 300 women from Warwickshire and Northamptonshire who used to come to Banbury to deliver, and some of those women may still come to the MLU, and some of them will choose to go to obstetric units in those counties.
Okay, and the gentleman over there. Yes, please, sir. You've been very patient. Thank you.
I'm Neil Owen. I'm a district councillor in West Oxfordshire, and I represent Churchill, Chadlington, Taston, Spelsbury, Dean and Sarsden.
Very impressive. What's your question?
That's a very rural part of the most rural part.
Sorry, can you...
I've got a question at the end.
No, if you hold the microphone up, we can hear you. We can't hear you.
And I represent that extremely rural segment of the most rural part of West Oxfordshire. Now, this is why this hospital in Churchill is so important. It is a special case. Chippy. Yeah, Chippy. I live down the road, so forgive me. And my question is, I've heard the panel's response, and I think you're very brave to go around the district and the county answering the questions. And you express support and appreciation, and you agree with lots of the things we're saying, that we can't bear to see the maternity unit go. So when it comes to the consultation period, after you've had the first response, presumably the panel and others will sit around and make the decisions. Am I right in assuming that?
So it will be the Clinical Commissioning Group board who will make the decision. So on the panel today, you've got 2 board members, so Paul and myself, and there are some other board members
So in other
here.
words, the board, as it's composed, will be making a decision. It's not going to the Secretary of State. So all the things you've heard tonight, and all the expressions of understanding at our plight, you will be taking on board and making decisions in the light of that. So I'm hoping for a positive outcome.
So we will make decisions in the light of what we've heard, but also we have to think about clinical safety, outcomes, and the ability to deliver the services. So that we have to look at all of those things together.
Okay, thank you very much.
All right, thank you very much. Now then, the next person is GP himself, I'm told, front row here. I know the councillors are keen to ask. Are you a councillor or a member of the public? Okay, so what I'll do is GP first, 2 members of the public, then I'll come to you, gentlemen. Yes.
Jonathan Moore, local GP. I'd just like to say that we've heard and we welcome, obviously, specialisation and the fact that we're going to bring services together in Oxford. But what is being painted through the videos is that it seems quite simplistic, that you go in, you have a short duration of very intense treatment, and then very quickly you're referred back out into the community, you're going to be back in your own home. And the reality of this is that this isn't the case, and often people need much more longer periods of subacute care, rehabilitation and intermediate care, and that cannot always be done at home and cannot be done safely. Therefore, places like Chipping Norton Community Hospital are absolutely pivotal. And we've been at this for about 15 years now. We actually got the brilliant new hospital up there from the closure of the old hospital, because that was the town's hospital, and that is why we have this fantastic unit up there. The GP surgery, the fantastic medical centre, was located right next to it so that we could provide more services, and we were hoping to develop much better into a subacute unit. And I know that obviously there are only 2 hospitals in the county, but there are diminishing numbers of community beds. There's certainly a diminishing number of intermediate care and subacute beds. And I just want to say that we would welcome so much if we could have investment and make sure that we have ability to care for people who cannot go immediately from the acute hospitals directly home. And provision is absolutely critical.
Dr. Paul Park.
Thanks, Jonathan. I completely agree about the fact that that it's not necessarily as simple as the message might come across. I agree that people can't, although the ongoing message is the best bed is your own bed, frankly, for a lot of people, that is not necessarily, that is specifically the case at that time. There are lots of places in between a hospital bed and your bed, as it were. And yes, the intermediate care beds here are obviously an example of some of those. I also think the intermediate care beds here are excellent. I do think it's really important that we maintain a decent number of options, as it were, for people, and scattered around the county for people to go into once they've come out of hospital. If you don't have that, you don't have the flow that we talked about in the first video, as it were. You can't get the patients to where they need to go, relatively close to home, but not necessarily at home if that's not where they can be, as it were. That said, yeah, we aren't, of course, asking about the future of Chipping Norton Community Hospital in this consultation, and I hope that we'll be able to invest more in Chipping Norton Community Hospital because it's a new build, it's a lovely building. Your practice is right next to it, and my word, it's shiny. And I hope everyone here appreciates it, as it were, because it makes my practice look like a hut. That is, by the way, absolutely no offence to everyone who works and goes to Hightown Surgery, which is a lovely place. Come on.
Dr. Tony Barrett, have you done? Dr. Tony Barrett.
I think the point I just wanted to emphasise, because it's so important this is understood, the release of the beds that has already gone on and that has already allowed the hospital to invest very substantially in services that support the intermediate care beds that were commissioned in the nursing home sector, that is very much about moving resource from being heavily located in the hospital sector to being located in a more community-based sector. Exactly what the balance of different kinds of beds and services is something I think we are still evolving. The intermediate care beds have a particular pattern of rehabilitation, of nursing and medical supervision, which is slightly different to what you get in a community hospital, and is different again to what you would have as a domiciliary package when you finally get home. So it's very much about having the right set of resources, but we're very clear that we need to locate more of those resources out in the community and have fewer beds in the hospital being staffed as if they were acute hospital beds, consuming a very large amount of resource to look after people who fundamentally no longer need to be in that kind of a hospital and who actually need, as you saw in the video, a much more homely environment where the emphasis is on rehabilitation, the development of more self-care, and a set of nursing inputs, all of which we can do in hospital, but which actually are much more complicated when they're muddled up alongside other people who are grievously ill and all the rest of it. I mean, you can imagine what it's like if you're medically well and you're next door to somebody who's desperately ill and confused and all the rest of it. It's not an experience that's conducive to your recovery.
Okay, getting lots of hands up now, which is great. The gentleman here first with the green coat and the sort of yellow collar, please. If you can keep your questions as short as possible, I'd really appreciate it.
Okay, well, I just want to read you something as well before.
Sorry, your name,
this
sir?
This is a quote from the Joint Commissioning Group. We are therefore proposing a groundbreaking partnership in Chipping Norton that will provide effective community hospital services in a new way. The service will not change from the current specification, which encompasses subacute medical care for people of all ages. The service will be specified by the Clinical Commissioning Group. And that was written by Sarah Liverdaeus, Deputy Director. However, in response to that, my question just coming. There was a note then from the Orders of St John to say we would not be prepared to surrender the beds for use by another provider. So you can see from that these documents show the Clinical Commissioning Group believed that the right model of care for Chipping Norton was NHS staffed and managed community hospital intermediate care beds to a subacute standard. And this was stopped by the Orders of St John, who wanted to use the beds to subsidise the care home. We know the Orders of St John has failed to provide the same service that was provided by Oxford Health since April 2016. So will the Clinical Commissioning Group now commit to reinstate our NHS intermediate care beds in Chipping Norton? It's what we...
Can we make that your question?
It is the question.
Okay.
We want those beds reinstated to the NHS. It's what we want, and it would meet two of your targets because it would use beds more effectively and it would provide better care closer to home.
All right, thank you very much. And, sorry, I didn't catch your name. Sorry, sir.
Clive Hill.
Clive Hill, brilliant.
Thank you. So we know there's a very strong feeling in this community about the hospital beds. I think, as we said at the beginning, those services are not part of this current consultation. We will take on board everything that's said, and also with Mr Hill and various other residents and Mr Courts, we are having ongoing discussions about the use of those beds, what you think they are, the data you've got and the data we've got, and that will continue, and this will all be part of our second phase of the consultation. Community services will be in the second phase of the consultation. And also, I just need to make it clear, Sarah Liverdes, who you mentioned, was a Deputy Director at Oxfordshire County Council. She was not a Clinical Commissioning Group employee. She's not... Yep, but she's a county council.
County Council, not CCG, apparently. And Dr. Paul Park.
Yep. And just to clarify, as everyone probably knows, or should do, about this ongoing very emotive issue in Chipping Norton, sadly, the intermediate care beds in Chipping Norton and elsewhere are commissioned by the County Council under social care rather than by the Clinical Commission Group under health. That was one of the, if I may say so, unfortunate fragmentations of the system that happened with the Health and Social Care Act back in 2012. So that is what we have.
Okay, now, the gentleman in blue has been very patient. Sorry, sir, just wait for the microphone here. This gentleman's second row back. Then I'm coming to the two at the front row, and then I'm going to do quick fire. Yes, sir.
My name's Peter Nuttall. I was educated in Chipping Norton. I live in Chipping Norton. But if I had a 30-year career outside, which involved 6 years as a director of a primary care trust in Cumbria. And I'm very familiar with the argument that says it's all very complicated and we need more specialisation, and because you're not good enough, we're going to shut you down. We have that argument in Cumbria about maternity beds. And believe me, if we think we've got a problem here of times in Oxfordshire, you try getting from Carlisle to Grasmere and back again. So we solve that problem by rotating people in and out, by taking people from the main hospital and rotating them in so that they got their continuum professional development and they were properly qualified, and we did have proper service at the maternity unit that was to shut down.
All right.
So I actually don't accept the argument about the stroke and the maternity, that it needs to be shut down.
So can we do that rotating system here?
Why not?
Is what you mean. Okay,
Why not?
Thank you.
Is the question.
Dr. Tony Barrett.
I'd like to talk about that we would talk about this as a step up, step down unit of the hospital in Chipping Norton, and I think it's absolutely vital. It's also absolutely vital if you shut beds down that the services closer to home are there, up and running and funded.
All right. Thank you, sir. So that question about rotating in so that you're getting a continual mix in, as we heard happened in Cumbria.
So it's important just to go back to understanding why training recognition was withdrawn several years ago. 4 deliveries a day in Banbury in the obstetric unit, not all of them requiring any input from an obstetrician. That is not a rich training experience. That is not something that doctors with high ambitions want for their careers. We were very fortunate that we were able to get people on the research fellowships who were willing, because they were already very substantially trained and wanted to do research, to spend some of their time servicing the unit in Banbury after training recognition was lost. But as you've already heard, even that arrangement proved fragile, and over time there have been fewer and fewer people willing to take that particular case mix. That leaves us then with advertising those posts as ones that are not recognised for training and need to be filled by people who are not simply trainees, but who are capable of independent functioning, who are capable of doing a caesarean section in the middle of the night, or capable of doing a forceps delivery in the middle of the night with no other medical assistance to do that. That requires quite a senior trained person, And that will not be happening every night that they're there, and their skills will be degrading. So that, of course, brings us to the question about rotation. And the issue about rotation would then be the numbers of doctors we would need to maintain skills by having people work in Oxford, to then have them have those skills not being maintained when they're working in Banbury. And I think you can do the maths for yourselves, that if we've got a very substantial number of deliveries going on in Oxford and a very small number going on in Banbury, we need a major augmentation of medical staff if we were to attempt to keep a unit in Banbury open for less than 4 deliveries a day on the basis of a rotational programme. You mentioned stroke. I just want to emphasise we're talking about 100 patients a year who would no longer go immediately to Banbury for their stroke management. I don't think there is any question that the outcomes are better for people who go directly to hyperacute stroke units. The evidence for that is absolutely clear, and it's overwhelmingly clear for that subset who will benefit from thrombectomy. And that is not something that can be dealt with by rotation, because that's about an entire multidisciplinary team, access to imaging and expertise. That's not about rotating a single person in. So while I understand the argument for obstetrics and don't agree with it, I don't think the argument holds up at all for stroke. And all the evidence around stroke and travel times is that the hour or so, if you want to be bleak about the travel time, less if you believe it can sometimes be less, that is not material to the outcome of a stroke if someone gets to a hyperacute unit.
Andrew Stevens.
If I could just respond to your second question. One of the things I've learned from the public meetings we've been holding as part of this consultation is collectively we're still not very good at describing the alternatives to hospital care and measuring them and describing them in a way that everyone understands. So if you'll forgive me, I'll quote some figures, and this is work in progress, to try and illustrate the fact that the resources we have freed up from those 146 beds have been ploughed back in to alternative ways of providing treatment. So to try and help us with this exercise of describing what it is we are trying to achieve together, we took a snapshot on the 5th of February of patients that we were supporting, so we as a trust were supporting, in alternative settings. So on the 5th of February this year, we had 159 patients who were going through, jargon alert, our ambulatory assessment unit. So those are units staffed by multidisciplinary teams, doctors, nurses, therapists, who are looking at, assessing and treating patients on a daily basis who don't need to be admitted. So we had 159 patients.
And sorry, ambulatory means they walked in?
Yep, and
right.
they can go home again on the same day. Right. So we had 159 patients who were spread between the John Radcliffe and the Horton. We had around just under 100 patients who are in nursing homes, private nursing homes, but who are getting an extra level of support from our staff, from social care staff, and from staff who are employed by Oxford Health, so that the nursing homes can look after those patients with confidence, knowing that they will get support where they need it, so that, again, those patients don't have to go into an acute bed that they don't need. We had 31 patients. We have another service, and again, jargon alert, it's called our Acute Hospital at Home. Again, it's a service that we provide where patients are alerted to us that they've got needs that need to be looked at there and then, but who can have that care provided in their own home, again, avoiding the need to come into an acute hospital. And then we've got another service then that is what we call our HEART team, so that's our Home Assessment and Reablement team. So those are members of staff that we employ who provide social care for patients who have either just been discharged or perhaps have turned up in our A&E department, but who don't need health care. They just need some social care to help them and rehabilitation care to help them get through a crisis. So that totals just over 500 patients that on that day we as a trust were looking after in a care setting other than an acute bed. And it's a shame that we're not better at describing it. And one of the things that I'd like to do and see out of this exercise is to work with members of the public to get a better way of describing that and getting an understanding of the different models of care that are available.
All right. I'm going to come to these councillors first of all, and just as I ask that councillor to be brief, I'm going to ask you to be brief as well. If we could just get the microphone to you, a quick introduction, and then we'll get going.
Thanks. Jeff Saw, District Councillor for Chipping Norton.
There's been much criticism of the fact that the consultation has been set up in 2 phases. And I've had a lot of people who've been said to me they're sort of worried about completing the sort of consultation because they're not quite sure what the implications of what they say might be when you come on to the second phase. So are you able to reassure us that that the decisions taken after the first phase of the consultation will not close off or narrow the options in the second phase? I think, Catherine, you sort of alluded to that earlier, but I'm particularly thinking about the effect on A&E at the Horton, community hospitals and community hospital beds, and, of course, the maternity unit here in Chipping Norton in what's going to be an area with probably an increasingly expanding population. Thank
All right,
you.
Jeff.
So,
Thank you.
so no.
Sorry, just before you start. Sorry, no, Catherine. A written question as well, which links in with that. Somebody who's not signed, but that's absolutely fine, says, with district councils objecting and the county council and some MPs to the split consultation, why are you still going ahead with the split consultation?
As I tried to explain in the presentation, the reason we've split it, and we think these 4 areas, 5 areas are urgent, so that and absolutely the decisions we take on this do not close down any options for the service areas that we are looking at for phase 2. Yes, we have had objections about the split consultation. We did discuss this with the Health Overview and Scrutiny Committee back in the autumn before we started, and agreed that we would go ahead. We know that individuals and councils are still pursuing that, but until we hear a good reason, or we're told, because there were some discussions that are going on with the Secretary of State, we have not been told to stop. As the panel are trying to get over, we absolutely believe it's very important that we do something about these services. We can improve the quality and the services available for this population, and we should be doing it.
All right, and again, I'd ask you to be very brief, please.
Steve Akers, Chipping Norton, Labour Party. Catherine, Paul, colleagues, in your introduction and in the consultation document on page 8, you cite, quote, financial pressures as funding does not keep pace with demand. You also quoted that there has only been a 1 to 2% uplift in funding in the NHS per year, when 4 to 5% is needed. So the question, if you as commissioners had the correct level of investment and there were not the 20 billion year-on-year cost savings being required by the government on the NHS until 2020, would still the same level of cuts in the transformation plan, either phase 1 and phase 2, both, because you know what we care about here primarily, but it's linked in to the whole county. We still want to know 2 very important things. Will they still be part of the STP plans if you had the investment? So can you give the reassurance that this community wants? We've lost too much already.
All right, thank you very much.
We want to retain our maternity unit. We want the subacute intermediate care beds, as Clive has explained, as originally commissioned, back in the NHS.
Thank you very much.
Thank you.
Who wants to tackle that one? Dr. Paul Park.
Yeah, I'll start. Your kind of implied question was, would we be doing all these things, any of these things, if we had the money, as it were, if we had more money? And the categorical answer is yes. In slightly longer terms, there are issues, especially maternity, are issues of workforce and of training, and the others are of quality and safety. Yes, we would do them whether there was the money or not, as it were. As for the reassurance around Chipping Norton Hospital, well, this consultation isn't about Chipping Norton Community Hospital, as we know, and therefore we are not asking that question. But doesn't mean that you can't, as it were, give the answers and the arguments in the consultation, and we will take that all on board for planning for phase 2.
Yes.
I suppose just to back that up from the trust point of view, the trust board has been involved in obviously the preparation of the consultation. All the proposals that are contained in this first phase of consultation have all been put forward by clinical teams They aren't being put forward by managers. There are clinicians saying what is in the best interests of the patient. And again, Steve, to respond to your question, if money were no object, would we still be putting this forward? In this first consultation, yes, we absolutely would.
And just in case there's any doubt, as the quality lead for the board, for the trust, and the medical presence on the board, I absolutely endorse all of that as well. Yep.
All right, there's a lady in white there with glasses who's been very patient. Thank you.
Thank you. First of all, I'm not a politician. I'm not on any committee. I don't belong to any political party, and I'm not a political animal. Excellent. But I am a very unhappy person because my sister, who doesn't live in this area, has recently experienced what happens when you start getting rid of beds, closing hospitals, saying you can't have your local care locally. I just tell you, on the 20th of November, she had a fall. It took 14 hours for the police to break in and find her, and she was sent to the local, to the main hospital. Good. She got the acute care. But since then, in the last 3 months, she's been shifted from pillar to post because nobody can decide where she has to go till her broken leg heals and they can get on with rehab. Her local hospital, something like the Horton in size, has actually been reduced to just one ward, and getting a place isn't very good. Now, my concern is, having watched what's happened to her, what happens when you say, oh yes, we'll have intermediate care? Where are you going to put them? My sister has been moved from one end of her county to another, and quite often under pressure. I won't actually use the word bullying, although it's in my mind. How are you going to guarantee that you keep your intermediate care where patients can receive visits from their family and friends and not be stuck out somewhere which is totally inaccessible unless you happen to have a car?
All right, can I just check, is your sister in Oxfordshire?
No.
No, OK, no, I just wanted to check in case.
No, but the point is...
No, I'm
what's
not distracted
for
the point.
Yeah, is what I see happening here.
I know. I just thought I'd make that clear. OK, so regarding the locality of care, the ability of relatives and so forth to visit, Dr. Paul Park first?
Yes, again, I'll start. Let me first say that sounds like an awful experience, really terrible. My sympathies to you, to your sister, to all of your family. That is an awful situation, and I, like any other doctor, have plenty of horror stories of patients and indeed relatives who have been messed about by the system. In the system, that sometimes happens. That said, that is not what we're doing here. What we're trying to do is make the system more effective, more rational, and make sure that people can go close to where their relatives or indeed they were. Get the care they need in the right time, and not be pushed around, not get shoved out of the hospital even despite not being fit enough, not get shoved from one care home to another because you have to get someone in now. This is about making the system flow more effectively, more safely, with better care for everyone, and that's what we are trying to do the best of our ability.
Andrew Stevens.
As Paul and Catherine have said, the intermediate care and community health care will be part of the second consultation. But the principle of getting people treated closer to home and in a more integrated fashion is very much behind what we're trying to do here. Paul mentioned, in the last fortnight, we've opened up a brand new scanner at the Horton, a 64-slice scanner, which means it's quicker, so we can see more people. It's also more sophisticated, so people who've had to come down from the Horton to Oxford to have their scan can now be seen more locally. And that's beginning to allow us to move some of that 90,000. So that's 300 patients a day will no longer have to travel down to Oxford. Yes, there are 4 or 5 a day who may have to for reasons of safety and quality, but they're more than outnumbered by the 300 patients a day who will be seen at the Horton. The other thing I think that I've heard from your story, and again has been a common feature of these meetings, has been the need for much greater integration between health, social care, the different bodies that provide care. From a patient's point of view, it doesn't matter who the organisation is. You want to know that your patients, your parents, your loved ones are being seen and are not falling through the cracks. And that's precisely what we're trying to do with the Integrated Care Hub that you saw on the video. Those staff are working together as a team. They're employed by different organisations, but they're all working together as a single team. There are social workers, there are therapists, there are doctors, there are social care workers, And that's absolutely what we're trying to achieve through these proposals.
All right.
And can I
Tony Barron,
just add to that, and obviously echoing the sympathies to you and your sister, there is nothing in our proposals that is about sending a woman with a broken leg into an inappropriate environment to be looked after. What we have been talking about is large numbers of people who were medically fit to be discharged, who were trapped in our hospital because there was not the means to care for them outside. We released a load of beds and the resource that we were able to redeploy to support those patients getting out of hospital quicker. We've treated over 480 patients through the intermediate care beds since that program began. And you know, that is what we're talking about here. We're not talking about chucking people out who have a medical need still to be in hospital. And just to be clear, we released those beds because we were desperately keen to deal with this problem of people stuck in hospital. We agreed that temporarily with the HOSC, the Overview and Scrutiny Committee, and as you now know, we've been asked by them to consult on that matter sooner rather than later, which is why we are. But this is already happening. We do not have lots of people, you know, with broken legs being discharged from hospital without treatment. So I'm really sorry for what happened to your sister, but that is not what we're talking about in this plan.
And there's a lady here at the front row, please.
Have I heard in the last few weeks of friends who are being sent to hospitals a long way from their own home? Oh, we haven't got any intermediate beds. Can we go back to perhaps caring about patients as being human beings? Thank you.
Okay.
Yes, we can.
I think the panel unanimously agrees with that last statement. Lady at the front in the pew, yes, thank you.
Thank you, I'm a councillor too.
Can we keep it really brief? I've nothing against councillors, but I have had two people say...
Well, you obviously
can you
do.
not
I've
ask
waited all
councillors?
night. First of all, I just want to put something straight. The Health Overview and Scrutiny Committee at the County Council, which is independent, actually did have to say, do this as a separate consultation because the beds had already been closed, as had the unit at the hospital. You are not allowed to do that without consultation. Also, that has now been referred, as I understand it, to the Secretary of State. This week, there was a 6-hour meeting with these gentlemen and ladies here and the HOSC again. They are not happy, and they're now having to come back for another meeting. But at that meeting, they also, some of them wanted to refer it again to the Secretary of State. Oxfordshire County Council Cabinet, of which I'm a member, did not support the consultation. And yesterday, it was pointed out by the CCG that it was about adult social care. That is not the reason given for not supporting the consultation. The consultation was not supported by Oxfordshire County Council Cabinet because we did not realise, or we don't know what the impact is on our services, because the consultation is woolly. There are no options in it. There's no cost-benefit analysis. And for the members themselves, we had an amendment to that that said, and that of the public, because we don't know what the impact is going to be on the public. Now, my question now is, given that you've talked about releasing money because you've closed these beds, that to me is a perfect example of putting that money back into the beds, the intermediate care unit here that was supposed to be independent from the care home. And I'm sure it would save you money in the long term as well as giving benefit to the patients. I don't know how much you've saved because I've said we've not had a cost-benefit analysis, but it seems to me if you've got doctors and nurses going all over the place to look after people in their own homes, it would be much cheaper if you had 10 people or 12 people in one place that somebody could come in all the time. And Dr. Moore's already said about working together with the GPs here. To me, it doesn't make sense. And also, this is an area of growth. You are going to have so many more people here that we need the facilities in the north of the county.
Let's start with that population growth question. Has that been considered in this part of the consultation? Catherine?
Yes, so all of the work we've done does take account of population growth. We use both the Office for National Statistics population growth, but also we know from working with the local authorities about where the big housing growth area is, what sort of population projections, and that's all been factored into the demands that we're expecting in the future. So again, going back to one of the things I said at the beginning, we are aware our population is growing in size and we're getting older, and all of that together, we can do some modelling and prediction of what the demand will be and therefore what sort of services we need in the future.
And the other bit of the question about what's happened to the money you've saved from the closure of the beds, what was that, Andrew?
I gave the figures of the snapshot we did on the 5th of February. Those are the services. So we aren't saving money as a result of these proposals. We are reinvesting it in the services that I described. So the ambulatory assessment unit, where patients can go in on a day basis, get assessed, get seen by a multidisciplinary team, have treatment and go home the same day. The additional social care that we as a trust are providing and that the NHS are funding rather than the county council having to fund it. So all that money is being reinvested into those alternatives.
Did you want to add on, Tony?
6 million. That's what the trust has spent on this programme.
And those figures are in the public domain and they're in the supporting papers.
And that's in the report as well. Okay. Now, I've had some people who caught my... Yes, the gentleman at the front, just over the side of the aisle in blue with a white shirt, please.
Can I just briefly return to maternity? There is a suspicion, and I think I speak for a lot of people here, in your split consultation, you mentioned the fact that Chipping Norton maternity may close. And I think by doing that, you've immediately made people think, are they going to make this decision at the Horton and then later on tell us that that's their decision? And I think that's a big worry. And the reason people are worried about it is because this has happened to us before. We were promised an NHS intermediate care unit, which was perfect. And immediately, your group transferred it to Oxfordshire County Council with no consultation whatsoever. Nobody was consulted on it, and now we've got an inferior service.
Dr. Kieran Collison.
I agree. It's very confusing ending up in that document. We at the CCG took legal advice, actually, on what could be included if it was phase 2. Can it be included or not? They originally said, no, don't include it. It's phase 2. Leave it out and include it only in the phase 2 documentation. They then came back to us and said, oh, actually, no, do include it because people will be interested in it and it's just a hint of what's to come later about things we're going to discuss and that kind of thing. So I'm really sorry. It is confusing. So if I could at least try and clarify, it is there, but as I said, when we come to phase 2, we're going to look at the whole county and we're going to look at each individual MLU. It's not just the one here at Chipping Norton. We're going to look at the others too and figure out, are they getting enough births there? Are they appreciated by the people who live there? Are they wanted there? Are they used? And we're going to be doing that for every single MLU around the county, and we can do that exactly the same thing here with Chipping Norton. And it's in a way, it's no different. We're going to treat them all in exactly the same way. So I do apologise that it is confusing. Maybe we, in retrospect, it would have been better to do that slightly differently, but apologies for that.
Dr. Paul Park.
And just to clarify your previous example, the clinical commissioning group did not hand over the intermediate care beds, voluntarily or as an interesting whim to the county council. That was something we were required to do because their intermediate care beds are something the county council are supposed to commission under the Health and Social Care Act. And I would like to say to Councillor Hibbert Biles, if she'd like more money invested in the beds here, then I suggest that as a councillor in Oxfordshire County Council and its lead for public health, that she push for that herself. No, that's not. I would disagree with essential sentiment that, especially given that we do. I mean, Lord, we do not wish to wash our dirty linen in public, but we as part of requirements, we give £10 million a year to Oxford County Council to support joint commissioning, and rather than the other way around, as it were. And therefore, if the County Council does wish to spend more money or change the way that intermediate care beds here in Chipping Norton work, then they can certainly do so, and we would not stand in their way. We'd be very happy for that to happen.
All right.
No, he doesn't.
Okay, there's a gentleman here in blue, and I want to ask three quick ones together. So the gentleman in blue, then the gentleman with the green shirt, and there's a lady here with a maroon scarf. So 1, 2, 3, very quickly. Yes, please, sir.
David Bishop, local resident. You talked very early on about a state-of-the-art hospital in Banbury. And I wondered if you could tell us a little bit more about that, how much it would cost, when it's likely to open, and is it likely to open?
Okay, the gentleman in green, please. So I just literally lovely quick questions like that, please. Yes.
David Hayes, Town Councillor and also Vice Chair of the Locality Forum. So I spent 3 years talking to the CCG. The issue that isn't raised in all the discussion about travel time is just how long it takes an ambulance to get to Chipping Norton. My personal experience is anything from 30 minutes to an hour. And if you believe in the golden hour, it's gone while you wait for an ambulance.
All right, thank you. And then this lady here, second row back. Yes, you, madam. Yes.
My question was about maternity. You just mentioned that it will be on the number of cases being used. Our maternity, as I understand it, in Chipping Norton, they just took women from quite a wide area, but they've been told they can't take those people in. And I think it would be very unfair if you went on past statistics. We were doing really well with our births here, but they've had their hands tied. Will that be taken into account?
All right, thank you. So, the first question from the first David, if I can read my own writing now, was the new services at the Horton. What will they be? How long? When will they be ready?
So we will need the outcome of both consultations before we can give you a definitive answer to that, because there are some services, paediatrics and emergency care services, that are in the second phase of the consultation. We are doing some initial scoping work, and we, as I've said, at this very month we've opened up a brand new scanner. Just before Christmas, we opened up a brand new refurbished endoscopy unit, building on investment we've put into the site in the past. So we're already putting some of the building blocks in. One of the building blocks we can do a bit more planning on is the diagnostic and assessment centre that's associated with moving those 90,000 patients. Our current initial estimates are around that would cost between 14 to 16 million pounds. So we're building that into our capital programme and doing some initial work with the planners, the local planners, Cherwell District Council, as to where it could go on the site and how many stories and what have you. So that's an initial piece of work we're doing. The other piece of work we're doing is to see, is there any other ability to begin that process earlier? So some of you will know that there is an independent sector treatment centre, the Ramsay Centre, on the site. We know they've got spare capacity. So working with the clinical commissioning group and with Ramsay, we're exploring the possibility of using some of that spare capacity, again, to move some of those 90,000 patients earlier before we have to do any new build.
The second David talked about travel times, which we've touched on before. Dr. Tony Barrett.
I think he was asking about times to get an ambulance here, and I really can't answer that. I think that has to be addressed to the ambulance service.
So we'll
well, there is nobody from the ambulance service here. So, well, is there? Is there anybody from the ambulance service here? No? Okay.
So what we would say is that as part of this process, the ambulance service are very much involved. So the ambulance service are involved in the process and are in supporting all of the proposals that have been put forward. So they are part of the same process.
And lastly, the lady's point about you have heard that mothers are being turned away, or you think they're being.
If you've got details of that, please tell me. There is absolutely no way that I understand that we are doing that at any of our MLUs. We want to increase the throughput of all our MLUs. The only thing I can think you may have heard is that in order to protect access for local women who are impacted by the fact that we've had to make the changes at the Horton, we have restricted access to the John Radcliffe for women from outside Oxfordshire and the Brackley and Byfield area, which is what we consider as our core catchment. You might be referring to that, but there is absolutely, as far as I'm aware, and as I say, if you've got other information, please let me have it, that we are putting any restriction on women going into any of our 4 MLUs.
Dr. Kieran Collison.
Yeah.
Can I just say, this is
Let me know, please.
This is exactly what this consultation is about. It's to be able to hear things. So I, as well as being the maternity lead, have never heard of that. So I'm not saying that it's not happening. I just don't know. But if maybe we can touch base after the meeting and you can give me some details and then I can look into it. Because if that is genuinely happening, then I want to know about it and I will take that forward. But I have no knowledge of that up till this point, so I'll come and find you after the meeting.
All right, it's coming up to 7:45. Time for 2 last questions, because I think we're running out of time. There's a gentleman there with his hand up and glasses, about 2 back from the aisle. Thank you, sir.
Good evening. Graham White, former UK Paramedic of the Year. You talked about closing or downgrading CCU at the Horton. My father was treated on the CCU at Horton. He needed transfer to the John Radcliffe. There was no bed available, and he died. How many more people would die if you downgrade the CCU at Horton?
All right, Graham, thank you very much for that. It's very difficult, obviously, for the panel to talk about specific cases, but as a general rule of point. Dr. Tony Barrett?
Well, obviously, I'm extremely sad to hear what you have to say. We can't clearly go into or understand the detail of why he needed to move or what it was that ultimately carried him off. What we can say clearly is that it is not possible to have at the Horton all of the equipment and expertise and interventions that are necessary. You mentioned CCU to deal with someone who's having a heart attack. And was it? Sorry, I can't hear because you've not got the microphone still. It's a capacity. Sure.
My point being is that if you've downgraded the CCU at Banbury, there's going to be more pressure on a John Radcliffe. There has to be. So if you've closed losing beds at Banbury,
all right,
just to be clear, we're talking about 40 patients a year who were requiring level 3 care at the unit at the Horton. 40 a year. We do not think that will make an impact on capacity at the John Radcliffe. And yes, from time to time, there are very serious pressures. I'm very happy to look into the details of your father's case if you don't feel that's been carefully looked at or explained to you or worked through with you. If you'd like to come and see me afterwards, I'm very sorry to hear what you have to say. But I don't believe that making that change for 40 patients a year in the context of the levels of expertise that we need on those units to give patients a good prospect of a good outcome, I don't believe that 40 is material.
Andrew Stephen.
And just to say, we are opening up additional critical care capacity both at the Churchill site and at the John Radcliffe site.
All right, and time for 1 last question. Somebody we haven't seen before. Yes, this lady with the yellow scarf, just in front of you here. Yes, please.
I was just wondering, with all these extra patients crowding into the Horton site, where are they all going to park?
OK, so Andrew Stevens first.
So just to say that we are in consultation, as I've already said, with Cherwell District Council as the local planning authority. And you will have heard our Chief Executive's statement at the HOSC meeting that we are looking to radically improve our car parking on all of our sites through the provision of multi-storey car parks, and improved access. So we're taking a range of measures to provide better access. We'll be looking to work with our county council colleagues who have a leading role on transport policy to seek to look to improve public transport wherever we can. We're looking to look at imaginative ways that we can get our staff onto site. We're looking to see how we can, for example, work with developers around new park and ride schemes, but also to, as I say, improve parking actually on the sites through the provision of much better traffic control that having multi-storey car parks on each of our sites would actually provide.
Dr. Paul Park.
And this is somewhat apocryphal, of course, but the point is that the 300 a day who are right now going to Oxford and generally have to drive or get volunteer transport or taxis, and none of which is particularly convenient for them. Many of them live in Banbury. Many of them can get to Horton much more easily by public transport or on foot. Banbury actually is I know it's just about Banbury I'm talking about here, but Banbury is, for instance, an area with a relatively low rate of car ownership as a town its size. in the country, and therefore it's much more likely that people will be able to go to Banbury, not by car, in a way that they certainly wouldn't have been able to go to John Radcliffe. But of course, parking is being looked into at the Horton as well.
All right. I did say, but I think we've probably got time to squeeze one last one in. Somebody we've not seen before, the gentleman with the beard at the front. You've not asked one yet this evening, have you, sir?
No, Paul Fisher. You quoted times from Chipping Norton to Banbury and the ambulance times. Would you please give accurate times? You did not include the journey time, which David's already mentioned, but you got out of it quite easily by saying you don't do nothing to do with the ambulance service. But please, if you're going to quote figures, please tonight, give accurate figures, please.
So the figures that we're talking, where were those figures from, and how were they provided, and do we know how recent they are? Tony Barron.
Yeah, well, the timings, as I understand it, come from the ambulance service.
I think the point that was made earlier was about how long you'd had to wait for the ambulance to get here before taking the time. The times that Dr. Berent was quoting was once you are in an ambulance, how long it takes, and those figures come from the ambulance service because every single journey that they do is clocked. No,
all right, okay. No.
We don't have ambulance.
Okay, so what... Okay, so what I guess some of that is that we've not got anyone from the ambulance service here, so it's difficult for you guys to quote. But have you been liaising with the various ambulance services in this area as to the consultation programme?
Yes, but I think the challenges we've heard tonight are valid challenges, and we need to go back and present those to the ambulance and do further work with them.
All right. At which point I will ask who in the panel would like to sum up. First of all, Elizabeth will ask to kick off. Catherine Mountford, giving you new names now, Director of Governance at the Oxfordshire CCG.
So thank you very much, everyone, for all your questions. So if I just give a bit of a flavour of what I've heard. So again, we've picked up issues around the split consultation and particularly concerns that what we decide in phase 1 might impact on phase 2. Lots of issues around access, transport and rurality, and I think additional information today. So it's not just about the actual travel time, it's how long you might need to wait for an ambulance to start with. So again, how do we factor that into what we're looking at? And then obviously we've heard an awful lot about the desire for the enhancement and protection of the local services that you have here in Chipping Norton, and particularly issues around the midwife-led unit and the intermediate care beds. And on those, again, I think I would reiterate, we absolutely hear what you say tonight. That will feed into it, but we are not, in this phase, consulting on changes to those services. So I think those are the sorts of things that have come through to me tonight.
And Dr. Tony Barron.
I think I'd like to say I understand the strength of feeling. It's very clear that many of you are very concerned about these issues. That is to be expected. What I want to emphasize is that these proposals were developed by our clinicians. They have been developed on the basis of evidence reviewed and endorsed by the National Institute for Health and Clinical Excellence in the case of the maternity services and the stroke services, and evidence from other systems that have very successfully done these kinds of transitions away from heavily hospital bed-skewed care towards care that encourages more rapid rehabilitation and mobilization and more support for people to be at home. These are difficult transitions for us as a population to get used to. We are having to change our ideas that a hospital is the best and safest place to put somebody, and that there may be better ways to look after our frail elderly relatives and others, and that those may, I guess, also exact greater burdens on all of us. You know, I have an older mother living in Oxford, and it may well be that I'm going to be forced to provide more elements of care than I've been used to. I think we have to recognise that with issues like Brexit, with issues like the economy not coming right, the speed it was expected to be, we have to make the best use of the resource we've got. We have to deploy staff in the best way we can to get what we think overall will be the best outcomes for us as a population. And I'm very confident that these measures in part one of the consultation do that, whether it's for individuals with stroke or needing critical care from the north of Oxfordshire, or the maternity service, or the much larger group of people who fetch up in hospital with a deterioration in their condition, mostly frail older people, and who need a rapid route out into much more community-based care. I'm very confident these are the right things to be doing. I realise that we may still have a long way to go to convince all of you of that, but that is my strong view.
And Andrew Stevens.
I think the last thing I'd want to say is thank you. I'd come back to some of the points I think I made earlier. I think we are learning a lot from these consultations. One of it is about how we describe non-hospital care. And I think one has got a strong sense of the feeling that people in this room are giving, that the fragmentation between ourselves and the different organisations is something that we need to get much better at. I think one of the things we also need to do through the consultation is not just explain what the world looks like from where we sit and from the hospital, but it's also put ourselves in your shoes, whichever community we're talking about, whether it's Chipping Norton, Monday we were at Wallingford, we've got a further series of these meetings. It's to actually try and describe what it looks like from the patient's point of view and from the community's point of view. So to describe the totality of care, not just individual services. So I think that's a challenge that I've taken away from this meeting and previous meetings. And I think the last thing I'd want to do is just leave you with, we have got an absolute commitment in terms of services in the north of the county, as Tony has said. For our board, these are exciting proposals. We think we are moving towards a proper vision for the Horton as a vibrant and positive hospital of the future that will see many more patients from this area, from the Banbury area, being treated at the Horton than is currently the case. So, yes, I'd go along with Tony that change can be uncertain, and there are going to be some elements of the changes that may be uncomfortable and may be unpopular. But I think ultimately we are moving in a direction where we are carving out a positive future for services within Chipping Norton and with the wider north of the county.
Okay, thank you very much. It's just a reminder that it doesn't stop here, obviously. At the back of the pack that I think you had on the pews when you arrived are the physical address to write into, as well as the email address, Facebook and Twitter. As I said, a record of this meeting will be put up on the website over the coming days. Just to announce that the next meeting will be at Tame on Tuesday at 3 o'clock, but perhaps of more interest for people here. The next one after that will be at Banbury on Thursday at 6 o'clock. Thank you and good evening.